to our Allied Health and Nursing Symposium. My name is Fiona McKinnon. I'm the General Manager of Allied Health and Pharmacy and Chief Allied Health Officer. Delighted to have Professor Liz McInnes here as well. So Liz and I will be doing the co-chair today for the Allied Health and Nursing Research Symposium. So wonderful to welcome you here today, as there's a great buzz in the room. I hope there's also a great buzz online, and we're hoping that everybody can hear us. Rita and Sophie and Jess and Amanda have been doing numerous sound checks, so we think it all is ready to go. But before we do get underway, I just would like to do some practical housekeeping issues. We've got the toilets just down the little ramp to your back behind you. Safety-wise, we also will exit either down through there or through these exit doors here. We're hoping that we don't have any dramas, but just in case we do, best to do that. And we do have a lovely view here, including the AC and D just out to the back of you here. So that is growing out of the ground in a rapid rate and looking absolutely fantastic, so quite inspiring. And I think that's very much the theme of our research symposium today, an inspiring and exciting and hopefully a day and a morning where you feel that you will go off and do your own research. We've got some fantastic speakers today for you, and I know that you'll have a really interesting, enjoyable and, as I said, inspiring day. But before we do get underway, I would like to acknowledge the land on which we're meeting today, the land of the Wurundjeri people, the people of the Kulin Nation. I'd like to pay my respects to any Aboriginal people who are here with us today, our patients, our staff, their families and their community, and to really acknowledge the owners of the traditional land. We respect them for the holding the traditions, the culture and the hopes of Aboriginal Australia. So we have, I think today, around 22, I'm looking to Lisa, people in our care who identify as First Nations people. So a really important process there and great acknowledgement. So we are in for a great treat today, and I will introduce Carrie, our keynote allied health speaker, in a few minutes. Liz will also introduce our keynote nursing speaker, John Thompson, and I would like to acknowledge before we do get underway the wonderful work that Rita and Amanda, who is online, have done to prepare us for today. So it's just been an outstanding bringing together of great teams and great expertise. The research week itself has been a very, very exciting week. Exciting day so far, but I'm sure today is going to continue that way. But Tam and Sue, I did see Sue, I hope you're feeling really proud of what you've been able to lead. And we had a wonderful launch last night. So again, really inspiring. We feel that we're the hospital or health service of choice. We hope that goes more wider with our Health Minister and Deputy Health Minister and Deputy Premier on site yesterday, so that was pretty exciting. So before we do formally introduce everybody, we do have coffee vouchers as well for people online. I'll talk to you later about that, but on the for people here, we'll make sure that we have those coffee vouchers as well. There will be some breaks during the course of the morning, but we're in for a great treat with our keynote presenters and then the lightning research presentations that will be fantastic from Allied Health and Nursing researchers. So we have 7 lightning research presentations there as well. Any questions before we get underway? So we're sort of feeling comfortable where they are. I should have mentioned the safety hazards just for speakers, just being very careful here. We've got all the IT set up, but we're making sure that everybody's aware of the cords and things here. So we will get underway, and I am delighted to welcome Professor, I was going to say doctor, but Professor, Associate Professor Carrie Lethborg, who is well known to many of you. Carrie has worked within the St Vincent's organisation for, I think, over 30 years, Carrie. It's an amazing contribution over those 30 years. as a social worker, as a social worker researcher, and really most recently focusing on inclusive health and health equity in her research. Great to see Vijaya and Christina here, also involved with our health equity research across St Vincent's Health Australia. Carrie's work has included developing the Inclusive Health Program, really identifying and supporting vulnerable populations, what St Vincent's is all about, our vulnerable populations, and integrating also trauma-informed care within the wider organisation. So very, very key and across the whole sector research. She has been, as I said, a really active clinician, focusing on social work, working in oncology areas and across palliative care, and has done her PhD in psycho-oncology, and her postdoctoral studies were at the Memorial Sloan Kettering Cancer Centre in New York. Carrie has also attracted, can you believe this, $2.5 million in research grants. So really impressive CV, and has presented at national and international forums, and indeed at SVHA Research Week this week. So we're absolutely delighted, Carrie, to have you here today. Carrie is going to lead us through a maze. Now, I know that sounds amazing and as well as being a maze, but when we were talking to Carrie and presenting, very much the information that was coming through from many of our clinicians is acuity and complexity. We're talking a lot about acuity and complexity. What does that actually mean? How do we have a framework? How do we quantify it, for want of a better term? How do we look at the qualitative perspective of this maze? So Carrie's presentation today will be navigating the complexity maze, addressing the evolving needs of patients and healthcare staff in today's landscape within half an hour. So I look forward to hearing Carrie's presentation. We will have some time for questions as well. Great. Welcome, Associate Professor Carrie.
Thank you, everyone. It's lovely to be back here. Some of you may know that I spend a good part of my time living in Launceston and zipping over here, but this feels very much like home. I want to thank Fiona and Rita for inviting me to present today. I want to.
Sorry.
Oh, can't hear me?
Everybody hear okay?
Louder?
Yes. Yeah,
yeah,
do a little bit louder for the online as well.
No, of course.
Okay, thank you.
I want to acknowledge Associate Professor Vijaya Sundararajan, who is the new Director of Health Equity Research Hub across SVHA. So all of you get to know the amazing work that she's doing. Christine Shiner, who is from St Vincent's in Sydney, who's also working in the health equity area. But probably mostly Lisa Brady, who is my boss and has been forever in social work. And there's all these kind of accolades that may be said about me, but this little badge is my proudest. It just says Carrie, social worker, because that's still what I'm most proud of. I want to also acknowledge where we are on this land of Wurundjeri country, and particularly here, which the traditional name of this area of Fitzroy is Nirago, which meant meeting ground. Many mobs would meet here, and I've always found that a real deep thought that this is where mobs met and where we continue to try and come together to provide the best care that we can. And yeah, I think that would be it. And I've already skipped on to my first slide. Okay, so is everything okay?
We're just having some people not able to access the meetings.
Okay, I'll go ahead. I want to start by just acknowledging that there is going to be some sensitive information presented in today's presentation. And by that I mean information that may trigger you personally inside because of either past experiences you've had in your life or some of the patient care experiences that we've had. And I know after many years of working in this area, that can happen to me when I least expect it. Something will come up and I'll go, gosh, that really gets to me today. And so one of the things that I think in terms of us trying to learn how to do trauma-informed care better is learning how to read our own bodies, and when things come up that are that trigger past experiences of our own. So I want to ask that you take care of yourself. Feel free to step away if you need to. Talk to someone about it if you need to. Or just acknowledge, oh, that's interesting, that thing's still coming up for me. It's the nature of working with human beings. It's one of the many juggles that we do. Okay, so this question has come up, and it's going to be my next area of research. So it's still at the early phases for me. But I keep hearing this question of, have hospital patients become more complex? Or in fact, if we were being a bit politically correct, it would be, have the lives of the people that we care for become more complex? And the sense that I get from clinicians is yes, but we're not quite sure how and why and what we are going to do about that. So in terms of my experience, I started here over 30 years ago, and I was a grade 2 social worker. So my caseload would have been some less complex people and some more complex people in it. And we would have a bit of a balance. So in those days, we were still doing referrals for Meals on Wheels and home help. That stopped only after a few years of me working here. And I've got to say, those patients, so they were people that we were pretty sure were going to do okay when they left, but just needed us to check if they needed anything extra. Those conversations were actually really useful, even though we kind of saw them as a simple case. And then I would have some patients, maybe in my caseload, that there were more complex issues. And I was working in oncology, so there was some of that, but there was a balance. And even as I went up in grades of social work, and so you'd kind of be expected to have more of those more complex patients in your life, there was always still a balance. And I think when I was talking to Lisa Brady about this a little while back, and she was remembering that if someone came in with a fractured pelvis, we'd go, okay, we've got 2 weeks. We've got 2 weeks to work with that. Whereas now, of course, that's actually not the case. Now, this is what I hear. I hear from my colleagues in social work and across allied health that every case is complex. And someone said to me the other day, I live in Tasmania and our health system is falling apart. You have to be really sick or really complex to get into hospital. And I think that might be the case here as well. But what I know is a lot of people, everyone that comes in and gets admitted has more than 2 or 3 things going on. It's much more like this now. Now, this question's being asked around the world because it's not just us that's feeling it. So I'll give you a couple of examples. There was a study done last year, end of last year, it was published in British Columbia. So, often the work that comes out of Canada is quite similar to what we would find with our system. And these guys looked over 15 years of adult patient data. So from 2002 to 2017, 3.3 million cases of patient data. And they looked at complexity, and they looked at multiple morbidities, and they looked at some health equity parts of the data. And this is what they found. Over those 15 years, patients are now 2.7 times more likely to be admitted through ED, 2 times more likely to receive treatment for 5 or more medical issues, 1.8 times more likely to be on multiple medications, and 1.1 times more likely to have an unplanned readmission. There's a whole lot of other data that came out of this study, which is really impressive to look at, because I looked at that and went, that is what I think we've experienced. So if you saw that in a graph, it's like over the last 15 years, the level of complexity has gone like that. So if that's what you have felt in your clinical work, you're not alone. It's not that you're not coping, it's that it's gone like that. There's a group in the UK who have done a microsimulation projection study. So they've taken data over a couple of years, I think 2017 to 2019, and then they've looked at projections of age, inequities in terms of income, services, a whole lot of different bits of data, and they've projected what's the next 30 years going to look like. And their suggestion from this is that there will be a 72% rise in the prevalence of multiple morbidities, that health inequities will just get worse. And a quote from that study is, there will be a surge in medical needs, multimorbidity and polypharmacy, leading to more intense and prolonged hospital encounters, which I think is what that's what our experience now. Thus say it's going to get much worse. Okay, so this answers the first kind of part of, are things more complex? And it's yes. We ask ourselves why. There's a simple answer, and that is that there's an ageing population, but that actually doesn't answer all of it. And actually there's a lot of data coming out around middle age. You know, we've focused a lot on ageing, but actually what's happening in middle age groups. We know there's rising conditions, diabetes, obesity, heart failure, cancer. Even though we're doing well in all those areas, they continue to rise. We know that mental health and substance use is exponentially rised. We know that there are changes in disease patterns. So whereas ischemic heart disease is declining, kidney disease and diabetes is increasing. So the theme you're going to hear me talk about is it's complex, and yet it's even more complex, and it's even more complex, and it's all connected. And, yeah. In Australia, I think 2 weeks ago, we got the data that for the first time in decades, our life expectancy has gone backwards. So that has never happened before in my lifetime. It's now started to go backwards. And of course, in relation to the amount of focus that we are supposedly giving to Aboriginal and Torres Strait Islander health, last week we got our latest scorecard from Closing the Gap, and we're finding that in terms of life expectancy for Indigenous people, there is no significant progress. Adult incarceration rates for Indigenous people are not on track. Child out of home care is not on track. And suicide rates, there is no significant reduction. So I'm going to put the first layer here. Are things more complex? Yes, they are, and it's about increased multiple morbidity, but it's more than that. So the next area that is happening for everyone around us is that life is more stressful. We know that inequity in terms of wealth is just getting wider and wider and wider. 31% of households in Australia who have mortgages are at risk of financial stress, risk of even losing their mortgage. 62% of low-income households are in rental stress. And this week, I was just hearing yesterday, this week is, I think, Loneliness Week. Let me get the exact term. Loneliness Awareness Week in Australia. And one of the bits of data that came out yesterday was that people whose financial needs are poor are 7 times more likely to be persistently lonely. There's a connection between, there are so many connections, it's overwhelming. There's a study that's done in the US, it's been done for decades, and it asks groups of people how many stressful days they've had it goes over a 3-month period, and there's regular, you can see over time how stressed people are. And if you look at the current data, which it looks at the 1990s to the 2010s, there's been a 19% increase in the population stressor days. And of course, social media, thank you. Social media makes us think that the second part of this is true. And actually, all our lives go like this. Doesn't matter how great our lives look, but what we see are just those stars at the top. And we kind of all go that and go, yeah, isn't it funny that we put up our best photos and only when we're happy and stuff. But actually, we know this is having a damning effect on all of us. We know that social media is increasing depression and anxiety. It's increasing violent behaviour. It's increasing loneliness and isolation. And it's reducing self-esteem. And we're starting to measure that quite clearly. We're measuring it more in adolescents and young adults, but we think that that's probably just because that's kind of the more obvious group. It's affecting all of us. So, increased stress of living, that's another layer. The next thing is, and in terms of these images, I was playing with my daughter's AI image creator. So that's where I've been getting these, anyway, images. The next thing is that there are known links between stress and health. We kind of always knew it on some sort of level, but when the ACEs study came out, so that's the study by Folletti and co, looking at adverse childhood experiences. So they looked at adults that had had at least 4 adverse childhood experiences, and they looked at their health outcomes compared to someone that didn't have childhood adverse experiences. We found that they were 2.3 times more likely to have a stroke, cancer, or heart disease. They are 3.2 times more likely to have chronic lower respiratory disease, and they are 37 times more likely to attempt suicide. So this study was shocking when it came out for a number of reasons. There was still some thought that children that have been damaged in childhood get over it and get into adulthood. It quashed that. It also could be generalised and has been since that actually any of us, when we go through trauma, it impacts us. It's an ongoing impact on us. And it made that link between something traumatising happening to us, and if we think of the people who live in vulnerable situations that we see, most of them have had at least 2 or 3 very traumatic things happen to them, that it's going to change things in terms of their health. So this study really just set the scene around stress and health. There's been a positive association found between number of stresses in middle-aged adults in the USA and mortality risk. A direct link. You put someone under enough stress, they are probably not going to live as long as someone who is being better supported. We did some work here, Vijaya and I and a number of other people, looking at patient data from St Vincent's Melbourne and St Vincent's Sydney. We looked at 8 years of patient data, massive amount of data, and we started to try and look at vulnerable groups and kind of what outcomes they were and what happened to them when they came through St Vincent's Hospital. The first thing we found was that 34% of the patients that we care for would be classified as socially complex. And this is with data that we need to even look further. So I think that's an underestimation. But at least if you think about your caseload, or if you think about everyone who comes through the door in ED, every third person, someone who's dealing with a whole lot of stuff outside of the hospital. And we looked at that across the 8 years, and what we found was that across the 8 years, we had an 11% increase in all patients, but 61% increase in socially complex patients. The thing is that this group accounts for 47% of our ED visits, 59% of ED lengths of stay, 69% of total admitted episodes, 83% of total admitted bed days. So whilst it's a bit over a third, actually the time it's taking up and requiring of us as clinicians it's most of what we do. And the data shows allied health is involved the most. Of course, nurses are there 24/7, so they're the ones seeing it too. So we add another layer, the link between stress and health. But there's more. There's also been an increase in risk awareness. So increased legal and ethical responsibilities to identify, report and safeguard patients and family safety and comply with relevant regulatory requirements. This has tipped social work upside down. We were already dealing with a whole lot, and it's not just social work, but social work carries these requirements, these very strict legal requirements in very focused ways. So we have NDIS, we have family violence, we have taking people to VCAT, safeguarding, vulnerability, cultural safety, all of these things that we need to be constantly making sure we are focusing on and adding, and the reams of papers, and of course the links. So you have someone who comes in with a disability and there's family violence going on and there's carer issues. That's not uncommon, and it's me not saying that to any, I'm sure all of you have seen that. We think about risk awareness, we know that there is more of a focus now and we are better at identifying family violence. And the data that came out a couple of years ago nationally would suggest that at least 32% of assault hospitalisations are due to family and domestic violence. We know that we still have a long way to go to identify everyone that comes in, but we're getting much better at it. I add another bit of data that's pretty heavy to this.
Attention all staff, respond MET, 7 East, room 16, bed 2.
There was a study done in Australia at a fairly large maternity hospital, and all the female staff were invited to participate. I think 47% did participate, so it's fairly high for this, and they were asked to answer some questions about their own personal experience around intimate partner violence, and 45% of the female staff had experienced intimate partner violence. So what I'm wanting you to do is see these layers. We are dealing with it when we're caring for people. We know staff have had their own traumatic experiences, that outside of work there is financial issues. It's just building and building and building. Here at St Vincent's in Melbourne, the social work department do an enormous amount of data collection around a lot of this safeguarding information. This just shows you the increase in family violence notifications that we collect from 2019 to 2020 to 2021. Some most recent data shows that since 2019 to 2023, they have identified 2,243 cases of family violence. About 30% of those are in the 65 and older age group. So, you know, that goes into the elder abuse area, but 70% are anyone else who comes into the hospital. And this will give you even more gasping, I think. You would expect probably that around 80% of the people that are being identified as being within family violence are victim survivor patients. 20%, 21% are perpetrator patients. As you would probably expect, most of the victim survivors are female, most of the perpetrators are male, but not all. But 40% of the victim survivors are being cared for by their perpetrators, and 74% of the perpetrators are being cared for by victim survivors. So the complexity of working with these families and how carefully you need to work with these families to make sure you're supporting, you're identifying, you're keeping everyone safe, and you're acknowledging the incredible stress that's happening, in addition to the medical issues that we're trying to manage, is complexity 101. I'm going to give you just a little snippet of another study that was done in social work looking at NDIS patients. So this was a medical record audit of 35 cases that had involved NDIS. And the first part of this was that the average length of stay was nearly 3 times that of general patients. And the reason for that was the incredible work that goes into ensuring a safe discharge is involved for these people. That includes working with them around adjustment to illness, especially if the person didn't come in with a disability and now they have a disability, accommodation issues, supports before discharge, possibly having VCAT involved, quite possibly having other complex psychosocial risks such as mental health and family violence, and waiting for NDIS plans. So these numbers, you know, they have these neon lights around them, but there's good reason for that level of complexity. Okay, so we add increased risk awareness on top of our pile. This was when I put into AI ambulance stacking. It's not me, it's, yeah. The additional thing is that whilst we can track how complex things are getting, we have the context of our work is that health system pressures have continued. And I stole a couple of slides from Vijaya's presentation, so I openly acknowledge that, but they're pretty amazing, so you should see them. What this is showing you are OECD countries, specifically around percentage of GDP that is spent on healthcare. This is 2019 data, and so it's the most current. And what you will see is that Australia is second only to New Zealand in the world in terms of how much money we spend on healthcare per capita. USA, way up here, Australia and New Zealand, way down here. Canada's kind of in the middle. Then, on top of that, our average length of stay, so this is still OECD data, for acute care ranks in the top 2 for efficiency of healthcare. So you'll see, sorry, that red line's not very good, but Australia here, 5.3. Now, if I was presenting this presentation, this slide in a different presentation, I'd be going, we're amazing because we're so efficient. We're more efficient than France and Germany and even New Zealand. But in the context of what I'm presenting you, that's actually crazy. Because what we're talking about is this growing complexity that is requiring more and more of us. And of course, data around readmissions, deaths once people have left hospital, families that fall apart because we send them home and maybe they're not ready, that's a whole nother talk. But this notion that we're efficient and we should pat ourselves on the back, I think we need to start questioning that, given this complexity. So in terms of health system pressures, current funding models, I believe, penalise providers for caring for complex and vulnerable patients, which is a little tricky when you work at St Vincent's Hospital and we promote ourselves as being very proud of the care that we give for complex and vulnerable patients. Actually, the way that we're funded really penalises that particular aspect of our care. The focus of funding has continued to be since I remember case mix funding coming in the Kennett years. The focus is on procedures and length of stay, not patient complexity or social factors. And the funding does not cover the extra resources needed for complex patient care, in spite of the fact that I've just shown you that that is what has increased, that is what takes up most of our time. The funding does not cover that. So if you're feeling stressed, that's part of the reason. Let's add that to our pile. What happens is there's a convergence of all of this. And if we look at it from a perspective of a day-to-day, and me being in the room with someone that I'm caring for as a patient, what I need to know, first of all, is the amount of stress the people that we're caring for are carrying. And that, yes, we're here to deal with their unstable diabetes or their broken arm or whatever, but we cannot get away from the noise that they live in and that many of them live in. But also, I can't get away from what that feels like for staff members who are walking in the room and seeing this and have to get going because they've got pressure to get someone of the bed clear, or not really sure what to do with all of this because we're not supporting people adequately. So what next? Data continues to be really, really important. We wouldn't be able to start saying that, yes, those numbers have gone up. It's not just something you're feeling if we didn't have the data. But this data is more than just kind of medical data. It's tricky because we're really looking into bits that show us how do we identify people with complexity. So it's important that we keep focused on this and we do it really well. But we can't have data without storytelling. And the storytelling needs to come from patients, people with lived experience, the people that are caring for them, the other silent people that deal with all of this when all is said and done, and clinicians, that we absolutely need to be hearing the stories. And the data without the stories isn't helpful at all because we don't understand it. We also need to really understand that if I give you all of that information, this is why trauma-informed care is so important. Because actually everyone who walks through the door here, you can assume are carrying a whole lot of things in their life that we don't even know about. And trauma-informed care doesn't mean that we all need to be brilliant at dealing with trauma. It means this. Let me read you this quote. There is not a human in this world who does not settle down a bit when they've been heard, seen and felt. Often that is all it takes, that we actually go, this must be really hard for you at the moment. I can see you're dealing with all this stuff at home. I can see you're scared about what we're doing. Is there any way we can make it any better for you? We did some work looking at patient complaints a couple of years ago, and many of them said, if someone had just stopped and asked me if I was okay, and actually that nurse that brought me in a cup of tea shifted everything. This is not about us fixing everything. It's about us acknowledging human suffering and looking it in the face and saying, I see you and I hear you. I believe we need to elevate the importance of the fact that hospitals are a window of opportunity. We know with family violence, there's been a lot of work done on coroner autopsy reports of women that have been killed by family members. Certainly Queensland have done quite a lot of work. One of the findings in that was that of all the different services they had been to, every one of them went to a hospital at some point. Now, they may not have gone to a hospital and said, I'm in fear of my life because of my husband, but they went to a hospital for some things. And for us to actually stop and try and go, while that person's here, let's do whatever we can. That goes against what I have been taught during the really lean times, because we're taught, deal with the thing in front of you, fix it, get it out, pat yourself on the back, you did really well. But when you're talking about people's lives that have had chaos in them for generations, for some of them, and you're the difference, because you go, let's pause, let's pull that match back, let's take a breath. Do we need to get some more supports in for A, B or C? Do we need to acknowledge this other thing that's going on? We can actually make an enormous difference, but we have to elevate the importance of that. We need to review current funding models in healthcare, and I'm counting on Vijaya Sundararajan to do that because she's really good at it. But this data, we need to be funneling that to funding bodies to go, it's time we look at different ways of funding models. And finally, and it kind of does come back around to social work, I think, a lot of planning and funding models for healthcare have been very linear, siloed. This is how we fund cardiology, this is how we fund ED, this is how we fund whatever. What we're talking about now is someone who's homeless, who needs cardiology, who also has young children at home and maybe need safeguarding. None of the people that we see follow those linear ways of that we kind of think about them in terms of our resourcing. It has to be about the systems, which is social work 101. It has to be the messiness that is human life, and that unless we fix this and support that and are aware of this, we actually won't get there. So poor coordination often misses health problems, risking a crisis or people falling through the cracks, and we do see that all the time. So having systems thinking is really important. And I want to finish with this image of social work and allied health, just with such great gratitude and pride for the work that you guys all do every day in this messy, complex system. Yeah, thank you.
Thanks so much, Carrie. I think that just resonates with everybody in the room, every clinician, every mission person, really absolutely resonates with everybody working in this room, just that complexity, and to actually have those layers. Carrie, I don't know, maybe it's just the scientists in all of us that we need to have that sort of systematic understanding, but that really, I think, goes to the core of research, identifying what the issues are, the problems, how do we actually do something about it. If we don't know what the issues are, we can't really do anything. So I think that resonates with everybody in the room, nursing, allied health mission, and research staff. So thank you very much indeed, Carrie. What an amazing presentation. So, yes, yeah, we do have some time for questions, and I would also like to acknowledge Sister Marianne Conroy,
yes,
who is in the room today. Wonderful, wonderful to see you, Sister Marianne, and I know that that presentation will absolutely have resonated with you. Sister Marianne is one of our amazing Sisters of Charity, so thanks so much for being here today. I know all the nursing and allied health staff who are in this room will really appreciate your presence, as well as what you do every day. Yeah, thank you. I'll open up the floor for questions. It might be a bit tricky the online, but if anybody wants to text me, happy to take any questions there. Anybody like to start us off? Liz is going to start us off. Wonderful.
Great.
Thank you for that, Carrie. That was just a great presentation, very thought-provoking. And I was wondering, I know you touched on it at the end, and it's a very complex problem because you need to be able to change government the way in which they fund health, but how can we change health systems to accommodate care for people with complex health and social needs, so they're not booted out of hospital much earlier than they should be? You know, you see that as a clinician and as a carer, and as you say, these people fall between the cracks and often go back to something worse than before they went into hospital, because now they're even more compromised. And it's incredibly frustrating that people can't stay in hospital longer to get fully better, and also to have some of their care needs addressed and packages sorted out for them. They're just not given that opportunity. As you say, there is an opportunity there, but I don't know how you change the thinking of the upper echelons of the health system.
So, I mean, one of the simplest ways to change it is to just show the simple data that, especially with people with complex needs, they come back and it costs more. And certainly the United States have shown that quite clearly. It is, there are a lot of misnomers about this, including aren't we amazing because our length of stay is really short. I don't think we should be patting ourselves on the back for that anymore. That needs to be changed. But what we know is that sending people home when they're not ready or their family's not ready, eventually will cost more. So we need to show that really clearly. Something like $18 billion more in the States was one of the studies I was reading last year, and should no longer be seen as a successful discharge, actually. So if we then adequately, I mean, that, you know, these staff can do this complexity. It's not that it's not doable. What's not doable is trying to do it without enough time and with all this pressure and this idea that it's because you haven't done something. Well, no, actually you're waiting on community services. You're aware that the carer is exhausted and needs some support, et cetera, et cetera. So there's got to be some shifts in thinking, but even at a financial level, we can argue this. I think it needs to be shifted. You know, there's a lot of talk at the moment about value-based funding and looking at value outcome for patients. I think that's kind of coming from the UK. There's a few different areas that are starting to look at, but ultimately just questioning some assumptions that we've had that this is the best way to do things. The reality is that allowing adequate time for staff and patients and families to deal with whatever upheaval has happened in their life means that they will probably not need to come back to hospital. So some of it is continuing to collect that data and be really clear about it, and us just not keep taking it of, you know, everyone is exhausted. And so I think I don't think it's as big. I think when you see that kind of data, it doesn't feel as big a concern to me as just the feeling of, gosh, things are, you know, it's actually it's quite clear what's happening, and we can no longer think that it's really impressive to get someone out of hospital quickly. Yeah, that's my thought.
Thank you, Liz. Thank you, Carrie.
Hello.
Oh,
but that was, I thought that was a great presentation.
Thank you.
Do you think things are going to get worse before they get better, as hospitals seem to function more like businesses now rather than providing help to the public? Because we see preventative healthcare funding is minimal, and we do get paid for discharges rather than healthy patients. So do you think that the complexity and then all this will get worse before it gets better? I know it's a bit
No. Look, the trajectory would tell us absolutely yes, because it's not just that those numbers are going up. We're still, cost of living is going up, mental health is going up, all of those things are going up, and that's why we really need to we need to be getting this data and feeding it back to government very quickly. And there needs to be some quite big shifts, because of course I'm sure you guys are all hearing, we've got to cut costs. We've got to find money from somewhere and cut costs. Well, yes, within the current view of how much should go to a hospital, we would need to do that. Whereas if we are able to show very clearly with data that actually we're not doing what we should be doing and we're failing people and we're failing our staff, then we need to actually rethink the whole way we consider what is enough. And of course, some of that is about being, more refined with our money, and there are more clever things that's happening all the time. I see, if you look at all of the allied health posters, there's so many great ideas about how can we do something quicker or how can we bypass that. Fantastic, but that's not going to solve the whole thing. But I think we need to be more and more aware of it, because my concern is that we individually carry it and we go, gosh, I'm stressed and I didn't get that case finished today, and that person, they're going home because everyone's agreeing, but I'm worried. That level of stress I don't want to see anymore. And I hope that some of that can go away if we start saying, you know what, yep, I'm doing the best I can. But I think it will get worse before it gets better, but all the more reason for us to put as much effort into quantifying this and getting that message out. And I would say any hospital that you went to would be saying the same thing. This is not a St Vincent's issue. but we are being penalised for focusing on vulnerable people.
Hello, can anybody hear me?
Yes, we can hear.
Oh, that's great, terrific. Hi from behind the screen.
Oh, hi, Carrie. Good to see you. I could familiarise the voice, but I couldn't.
You can't
Harry,
see.
you can ask a question.
Okay, great. Look, I'm the clinical director of the Barbara Walker Centre, which deals with chronic pain. And chronic pain, like a whole lot of other, and I'm a rehab physician. Chronic pain, like a whole lot of other disorders of what I would call distress, including autoimmune diseases, mental health, things that lead to increases in cancer, like obesity, childhood learning and developmental difficulties. All these things are going up, but they're only going up in the West and in certain social environments. The problem that we've got in medicine is we tend to look at every illness through a microscope and not a telescope. And you know, the medicalisation of what essentially are a bunch of socially driven issues that are impacting our biological health won't be fixed if we think that this is going to get better with, you know, hospital admissions and not preventing these things from occurring. So, you know, chronic pain is going up, and we know that we can make people biologically better by just changing the support they have in their environment and even the way they actually conceptualize and think about their body. Because there are a lot of medical drivers and cultural beliefs that are actually changing the way our bodies work and the way we experience them. Now, this is all sounding very woo-woo and definitely not medical, but I think most of the illnesses that present and even bad behaviours, I think stem from big changes within our culture that are causing us to become dysfunctional at a physiological level. And things like, we talk about resilience, but resilience is not an individual or a person's inner resolve to get better, because it's usually, you know, the people that I see who've got chronic pain are very tough people and have been through childhood trauma and all those things that will predispose you towards a whole variety of illnesses, including early mortality. But what's broken down is the social fabric that keeps human beings together and able to absorb the daily shocks of life. So we've become more and more atomized. We're all living individually in our houses, family breakup, driving single cars, the loss of community, the loss of belonging, the increase in loneliness is driving a lot of immune changes, including chronic pain and mental health disorders and autoimmune disorders. Now, medicine at this stage is more interested in sort of looking at providing, you know, pharmaceutical options to treat what is essentially a social ailment. And it's not until we start researching and looking at cultures that don't have these problems, which are a lot of non-Westernized cultures, that we can start making sense of why it is that we're getting sicker as a people and we're presenting medically in tertiary departments like the emergency department for what essentially is doesn't occur in other countries for a variety of social conditions.
Harry, sorry, I'm going to have to interrupt you there. Thanks so much for those comments and really appreciate that that reflection, I think, and that will go for all of us here, and I'm sorry to cut you off. We're just got some tight time frames here.
Sure.
Linda, I might need to ask you to ask your question in the quick break. Is that okay?
Yeah, absolutely.
Is that right? Thank you. Thanks so much, Linda. Thank you, Harry, for those comments and those reflections. I think that really brings that so well together, that reflection very clearly, the learnings across nursing, allied health, medicine, mission really comes to the fore in that presentation. Many of us around the room are leaders, researchers, so really some really strong take-home messages for all of us, I think. Please join me in thanking Carrie, who's really and really what an amazing presentation, Carrie. So